to start his talk on role of sentinel node biopsy in oral cancer. Natarajan, are you there?
Good evening, sir.
Yeah, good evening.
Yes, sir. I'll just share my presentation.
So Natarajan, Dr. Natarajan is assistant professor in head and neck surgical oncology at Christian Medical College, Vellore. Over to you, Natarajan.
Can we see the slides?
Yes, sir, we can see the slides.
Yes, sir. So I'll start. Good evening, everyone. Opportunity to touch upon this topic of sentinel node biopsy in oral cancer. So I'll be going in this order with an introduction and a look at elective neck dissection till now, the evidences and stuff, and followed by the history of sentinel node biopsy in oral squamous cell carcinoma and the SNB procedure as such, and the evidence for the SNB in especially in oral squamous carcinoma, the guidelines, and I'll conclude after that. So coming to head neck squamous carcinoma, as we all know, it's the 8th most common cancer worldwide, and 33% of them have occult cervical disease, and they are undetectable by the current imaging modalities like ultrasound, MRI, CT scan, and PET scan. So why cervical metastasis is important? It's because that it's associated with a 50% reduction in cure rates, and more so when extranodal extension is present. So consequently, the current guideline is that if the estimated chance of metastasis in the neck exceeds 20%, the current practice is to offer an elective neck dissection. So does addressing the CN0 neck surgically improve survival outcomes? This question was answered aptly in 2015 in an RCT published from Tata Hospital, where they found that at 3 years, patients who underwent elective neck dissection had a higher overall survival and to prevent death, and 4 patients the recurrence relapse patterns, the nodal relapse patterns. Patients with therapeutic neck dissection had an advanced stage of nodal recurrence and also a higher incidence of extracapsular spread. This translated to lesser chance of resectability when patients were observed instead of electively addressing the neck. This was reiterated in a subsequent study, which was an RCT along with a meta-analysis. They also found that both the overall survival and disease history survival was favored in END with a better hazard ratio. In addition to the survival advantage, END can help in accurately staging the patient pathologically and to deliver appropriate intensification of the treatment. So what is the extent of elective neck dissection? This can be gathered from this paper of published in 2014, where 583 neck dissections were followed up prospectively. They found out the metastasis pattern to the neck in terms of different subsets of oral cavity. What they found is that majority of the neck metastasis occurred in 1B region, and for tongue along with that in level 3 and level 4. So level 4 runs along with it.
You're missing. I think your connection is unstable. We're losing you in between.
Also injury to the recurrent spinal accessory nerve. So they found that level 2A positivity predicted level 2B node positivity and also level 5 positivity. So since the level incidence of metastasis level 5 was very low, SND to 1 to 4 is effective in a clinically node negative neck. So the summarizing just to the existing guideline. N0 neck, the standard of care is prophylactic neck dissection. For an N+ neck, SND is sufficient in case of N1, N2. This is without extracapsular extension with a small volume nodal burden and may require adjuvant radiotherapy or depending upon the histopathology report. MND or RND can be done depending upon the nodal status. So if such a gold standard exists, so what is the problem with an END? The problem is twofold. One, almost 70% of the patients who undergo elective neck dissection become PN0, meaning they have undergone a neck dissection without the need for it. It means there is no occult nodal metastasis. And the second problem with an elective neck dissection is the nerve damage, which is actually quite morbid. This data is from the STEM study, where they have shown that almost 40% of the patients who underwent neck dissection had nerve damage, and 5% of them had grade 3 or 4, which is quite functionally debilitating. So to counteract this problem with elective imaging to replace selective neck dissection, to answer this question, we can quote see two studies, which were first study by Liao et al., which looked at different diagnostic modalities like ultrasound, MRI, CT scan, and the second study by Kaisas et al., which looked at especially a PET to evaluate cervical nodal metastasis. Both the studies concluded that there was no significant difference in sensitivity and specificity across the various imaging modalities. And for the PET, the sensitivity was just 50%. So this question, we can safely say that diagnostic imaging cannot replace elective neck dissection. This brings us to the concept of sentinel node biopsy. It was first started by the urologist Ramon Cabanas for the carcinoma of penis, and simplified by Morton and Alistair Cochrane. They started the concept of sentinel node biopsy for melanoma. So what is a sentinel node? The sentinel node is the initial lymph node upon which the primary tumor drains. In other words, the sentinel node is also called as a first tier node or the first echelon node. This is the lymph node on the direct drainage pathway from the primary tumor. I would like to bring upon certain caveats for this definition of sentinel node. First question will be, is the sentinel node the nearest node to the tumor? Not always. The lymph node from the primary tumor does not necessarily travel to the nearest node. It follows the metastatic pathway. Second question is that, is the sentinel node the first node to appear when we do a scintigraphy? That also may not be the case, because we can have multiple sentinel nodes. So instead of having the definition of a first node, we should always consider the term first echelon and the first tier nodes. So all this, whatever node appears in scintigraphy, are all considered sentinel lymph nodes. And come to the next refinement, is the sentinel node only the hottest node in the scintigraphy? No, because two reasons. One, the tumor can grow so much that it can obstruct the lymph flow to the true sentinel node, and we'll have some other node which is picked up as a false sentinel node. And secondly, if the distance between the node and the gamma camera is deeper, then the uptake will be different. This is called the inverse square law of physics. For these two reasons, it is not always only the hottest node which lights up in scintigraphy is the sentinel node. So coming to the history of SNB in early oral cavity cancer, this excellent review by Arjun Singh et al. Actually, I would suggest that everybody go through this review, because it summarizes from the start to the recent concepts in the sentinel node biopsy. So it started with, for oral cancer, it started in 1980s and early 1990s by Hildman and Alexandra, and followed by a first conference which was undertaken in head neck in Glasgow for head neck cancer especially. So in that conferences, the preliminary guidelines were laid, and the first guys to look up in a big way was the Dutch multi-center study, where they found that the sensitivity in the negative predictive value was upwards of 90%. By two randomized control trials from Japan and France. So we'll be looking at these three in detail subsequently. So the SNB procedure, it can be the sentinel lymph nodes can be identified by three techniques. The preoperative dynamic lymph needs to be injected on the periphery with a sulfur chloride technetium 99. This is radio labeled, and subsequently the patient has to undergo a SPECT scan followed by intraop examination by a gamma probe. So coming to the blue dye or the dye as such, you can see in the picture that once the dye is injected, we can see the staining of the node by the blue dye. The problem with the dye is that it needs wide exposure of the skin incision to look at all possible nodes and also the staining problem. So to counteract the staining problem, ICG has been recommended by the SENT group for seeing this dye-based assessment. Excuse me. Coming to the second aspect is a preoperative dynamic lymphocytography. A SPECT image or a combination of SPECT CT image is done after the dye is injected to look at functional and three-dimensional location of all the possible sentinel lymph nodes, which are picked up radioactively. Then the patient is wheeled into the theater for a small incision followed by SPECT scan at the radioactivity to gauge the radioactivity. So once all the lymph nodes have been sentinel nodes have been harvested, it can be subjected to different types of pathological investigations like frozen section, imprint cytology, standard histopathology, or serial step sectioning only, or standard histopathology with step sectioning and IHC. The first two types can be used to assess intraoperatively, but the last three needs time for the processing to happen. So the sentinel lymph node is halved in a single section and taken for frozen section and histopathology. The other half is step serial section that with the thickness 4 picometer thickness with a gap of 150 picometers, and it is divided into two halves. One is routine histopathology H&E staining, and the other is subjected to IHC. So based on this as extensive assessment, the type of lymph node metastasis can be categorized into three types. One is a macrometastasis, the definition given by Hermann et al. In 1999. It says that metastatic deposits more than 2 mm in diameter are classified as macrometastasis. The second type is micrometastasis, the size criteria being 2.2 mm to 2 mm, with the presence of contact, invasion, penetration of vessels, and stromal reaction and tumor cell proliferation. If none of these factors present and if the size is less than 0.2, it is called as isolated tumor cell. So what short look at the advantages of SNB: it decreases the morbidity, it improves the identification of skip metastasis, unexpected drainage patterns, and it improves the histological evaluation because we follow an exhaustive histopathological methodology. The problems is that first I'd like to see about the fluoromorph tumors, because it has a shine-through effect. Since the dye is colloid is injected to the primary tumor, nodes present in level 1A will have a erroneously high uptake in the gamma probe because of the shine effect, first of the close proximity anatomically. Second problem, limitation of the surgeon's learning curve. And thirdly, the operating room logistics. This is actually very important because the infection is to the primary site and the lymphoscintigraphic imaging will take from minutes to several hours. And after the injection and the the biopsy ideally should be performed within 3 to 6 hours. And there's a problem of lack of spatial resolution in the gamma camera. And last problem will be the lack of prognostic significance of micrometastasis and ITCs. So coming to the evidences, the evidence I've classified into evidence for diagnostic accuracy, survival outcomes, QOL, and cost. So this is all the major studies I've put together, looking at the diagnostic accuracy. If you can see the third column, in all the studies, the false negative rate is around above 85% and a higher negative predictive value. 3 meta-analysis also corroborate the same conclusion, where the identification rates almost 96% and with a negative predictive value of upwards of 94 to 98%. Published randomized control study. This SENT study was done in 480 cases, which were recruited prospectively from 14 European centers, and the sentinel node biopsy was done as previously mentioned, and the deposits were reclassified into ITCs, micromets, and macrometastasis. The positive necks, the completion neck dissection, positive SLNs Completion neck dissection was performed within 3 weeks. The total detection rate detected metastasis in 23% of the patients, and 15 patients who had SNB negative initially developed neck recurrence, who were observed actually. So looking at the table, we have the high negative predictive of 95%, it's a sensitivity of 86%, and 14% false negative rate. Looking at the survival curves, when compared to SNB positive versus SNB negative, the survival was better in patients with SNB negative, and when classified according to the stratified according to the number of positive sentinel nodes, patients with lesser number of positive nodes had better survival. And coming to the type of metastasis, when stratified according to that, patients with micrometastasis and ITCs had a better survival as compared to macrometastasis. So concluding, the study concluded that it is a safe oncological procedure with a DFS of 92% at 3 years. It is effective in diagnosing metastasis, micrometastasis in more than 99% of the patients, and it identified unexpected drainage in 12% of the patients. There was no risk of tumor spillage, spares unnecessary neck dissection, and the false negative rate of 15% was comparable with the melanoma cohort in the MSLT trial. The salvage neck dissection is not complicated as tissues was not violated, as we had done the SN biopsy in a small incision with a limited dissection. And this helps to classify the types of metastatic, which has prognostic significance as evidenced by improved survival in ITCs and micrometastasis. Coming to the next recent trial, first I'd like to look at the equivalence trial, which was published in by the French group, Garrel et al., where they randomized T1, T2, N0 oral and oropharyngeal cancers to 2 arms, elective neck dissection and sentinel biopsy, where frozen section was done immediately after sentinel biopsy. Patients with metastatic SN histone frozen section were completed immediately. Patients with negative sentinel biopsy underwent step serial section and IHCs, and when they were detected metastasis, completion neck was done, and if they were negative, they were observed. The primary main outcome was 2 year neck node recurrence-free survival. The secondary outcomes were loco-regional recurrence-free survival, DSS, OS, and the functional outcomes, which were first looked at. Till this study, the functional outcomes were not given so much importance. But in this study, the hospitalization length of stay, neck, shoulder functional morbidity was assessed, and the number of physiotherapy prescriptions was taken as an indirect indicator for the functional impairment. So the mean follow-up was around 5 years. Around 307 patients were randomized to both arms, and ultimately 140 patients in each arm were analyzed. When we look at the recurrence rates without relapse of the primary, it was observed in 10.1% in the neck dissection arm as compared to 9.3% in the SN arm. This was not significantly different. So this answered our first question regarding the neck node recurrence-free survival. And the other parameters like loco-regional recurrence-free survival, OS, DSS, all were equivalent. Coming to the functional impairment, the hospital stay length was significantly smaller in sentinel node arm, and the physiotherapy prescription rates and the arm abduction tests actually were significantly improved in sentinel node arm, but the advantages lost after 6 months of surgery. So after 6 months, the rates of prescription and the arm abduction tests were similar in both the groups. The next trial, what I wanted to see is that the Japanese trial, which was published in 2021, this is a similar study, randomized phase 3 trial in 16 Japanese centers. This was a non-inferiority trial where they looked at SNB versus elective neck dissection in T1, T2, N0 oral cavity squamous carcinoma. This study had a primary endpoint of 3-year overall survival, unlike the previous study. So after a median follow-up of 3 years, the SNB group had a non-inferior OS at 3 years as 87% as compared to 86%, and also a non-inferior disease-free survival of 78% as compared to 81% in the neck dissection group. And the functional assessment was done in terms of neck stiffness score, constriction score, pain, numbness, shoulder drop, reach above neck appearance, and arm abduction test. All these were significantly better in SNB group till 12 months. I mean, at 1 month post-surgery as compared to the elective neck dissection group. So the concluding, All the three trials have a comparable false negative rate. It was especially lower in the French group, which is only 8.6% because of extensive step serial sectioning as compared to improving cytology in the Japanese trial. And the incidence of macrometastasis is also similar, and micrometastasis and ITCs are also similar. And the survival outcomes were also comparable. So if so, based on these three, we can come to the conclusion that the SNB is accurate, it is easy to do, and it has a comparable false negative rate, and the pattern of recurrences is not very bad as compared to an elective neck dissection. So, coming to the next question of cost effectiveness. Now when we look at cost effectiveness, in this prospective observation study by Head and Neck Oncology, published in 2016, they found that the SNB group required pathological assessment twice and surgical intervention twice in case of a positive sentinel node. And in head-to-head comparison, SNB was found to be 42% less costly than elective neck dissection in true negative patients. But in true positive patients, they were 33% more costly. And when we look at the natural progression of patients developing recurrences, even in the SNB arm, the pathologically node positive patients that underwent SNB incurred 17% more cost than elective neck dissection. They had put up a flow chart where we should see this flow chart in two different ways. One, the left vertically, patients who straight away underwent neck dissection. They incurred a cost of around $1,400, and the hospital stay was around it's a mean of 5 days. But patients who were randomized to SNB first had to undergo an ultrasound FNAC or a CT and MR, which was that cost had to be added, and they will be deemed CN0, followed by SNB. The cost for each cost breakup I have put up, and when they are positive and negative, if they are negative, the observation, when they'll be put on observation, the cost is lesser. It was $1,050 compared to $1,400 for the elective neck dissection. But the positive group, the patients will undergo a second surgery followed by a second pathological assessment, and in presence of ITC and MI, according to the current guidelines, they are considered as node positive. So if we add that, the number of patients undergoing neck adjuvant therapy will be higher in SNB because of the robustness in identifying ITCs and MIs. So the cost increases almost triple, around $4,000. So we can understand that the cost effectiveness is, in terms of cost effectiveness, SNB lags behind A and B. So coming to the guidelines, I'd like to bring to the attention this surgical guidelines, which was published in 2019. This is a consensus guidelines on SNB. This gives the patient selection criteria and the type of dye to be used and everything. I'll look into this guidelines as a comparison between the first conference, which was done in 2003, and the SENT study, and 2019 guidelines, which I had referred to previously, and 2 randomized trials. So when we looked at the case selection criteria, according to the guidelines, any primary tumor that can be reliably resected with adequate margins and defect required locally without requiring access to the neck can be taken up for SNB. Whereas we can see the varied inclusion criteria of the 3 trials and also the first conference. Secondly, what is the agent to be used in SNB? According to the guidelines, technetium 99 nanocolloid is the preferred agent. Also, ICG is advised for FOMT, fluorophore tumors, to avoid the shine-through effect. Blue dye is not recommended because of the problems which we had discussed already. But in the 2 trials, phytate was used in the Japanese trial because of increased tissue adherence. And the Garrel study, there was no clear mention of the type of agent which was used. And the criteria for classifying SNB is clearly mentioned in the guidelines as gamma count at least 10 times that of the background and 10% of the hottest node excise. So, but in the RCTs, it is surprising that the criteria for classifying SNB is not clearly mentioned. And coming to the extent of neck dissection, if SNB demonstrates any type of metastasis, be it macrometastasis, micro, or ITCs. In the SENT trial, all underwent completion neck dissection. But there is a difference in the randomized control trials. For the French group, ITCs were not deemed metastatic and they were observed. whereas micrometastasis and macrometastasis underwent neck dissection. But in the Japanese trial, all patients underwent neck dissection, and levels 1 to 4 was addressed. And for adjuvant treatment is not clearly mentioned in those guidelines, but in the two trials, adjuvant radiotherapy was used for ENE surprisingly in the Japanese group, and institution discretion was used for giving concomitant CTRT. So what we can conclude is that there is no robust guideline, and because of lack of evidence, and also there is no robust guidelines on how to manage micrometastasis in ITC. If we blindly take them as consideration as metastasis, many number of patients will end up receiving adjuvant radiotherapy because they technically classify into PN1 disease. So concluding, the current benefits of SNB include a higher QOL, better osmosis, better solder function, and detecting aberrant lymphatic drainage patterns. But the challenges are technical ambiguity in terms of the type of dye used and the type of classification which was used, and it's labor intensive, and most importantly, it's costly. So SNB is a rigorously evolving practice, and more efforts are needed in standardizing the protocols for SNB procedures and the criteria to intensify therapy across the world. Thank you.
Thank you, Raj. So we'll now move on to the case discussion part. And for that, I would like to invite Dr. Prashant Pennamadu. He is the professor at Jitmar Pondicherry in surgical oncology. Hello, sir. Dr. Vidisha Tunjapurkar. She is Associate Professor of Head and Neck Surgery at Tata Memorial Hospital, Mumbai. And Dr. Madan Gupta. He is a consultant of Head and Neck Surgery at Medica Hospital, Ranchi. For case presentation, we have Dr. Mukesh Shah. He is an MCH resident at Tata Memorial Centre, Mumbai. Mukesh, please share your slides. Now, before we proceed, I would request all the attendees, especially the residents, to please spread the word to all your fellow residents and colleagues to attend this meeting, because we have a very good talk to start with, and they prepare for you. The topics are selected so that you understand what the thought process is for the examiner and for the seniors for managing it. Like Dr. Natarajan today very well presented about the importance of the sentinel node biopsy. And I would also request the seniors to ask their juniors to please attend this session. Thank you so much. Please, Mukesh, you may start. Host has disabled रखा है. कर दिया. Allow our participant only.
Yeah, hi, Asim. Am I audible now?
Yes.
Yeah. I couldn't unmute. So, yeah. Hi, good evening.
Good evening. Dr. Vidisha?
Yeah, hi, Asim here.
Hello, yeah. Mukesh, yeah, and Dr. Madan, are you there?
Yes, sir. I am here only.
Yeah, please, you please may start now, Mukesh.
Hello.
Yes, Dr. Mukesh, please
Yes,
go
sir.
ahead.
Good evening, everyone.
Today I will be presenting a case on buccal mucosa cancer. I will start with my patient is 58-year-old male from Supaul, Bihar. He is vegetable vendor by profession. Presented to our OPD with chief complaint of ulcer over the buccal mucosa on right side for last 3 months and with pain for last 2 months. So he was asymptomatic 3 months back when he first noticed a small ulceration over the right buccal mucosa, which was initially about the size of a finger width, which was gradually increasing and has come to attain the present size. It was associated with pain over the ulcer, which was non-radiating, and the pain got aggravated on chewing and gets relieved with painkiller. Patient was initially treated locally with antibiotic and oral set. However, it did not improve and was referred for further treatment. He does not give any complaint regarding restriction of mouth opening. He is able to swallow and speak well. There is no history of loosening of tooth. There is no other ulcer elsewhere in the oral cavity. There is no history of redness, wound, or puckering over the overlying cheek skin, and there is no any swelling in the neck.
Yeah.
He also doesn't give any history of cough or hemoptysis, or there is no history of bone pain, no history of significant weight loss, or there is no family history of malignancy. Patient gives history of chewing tobacco for last 30 years, about 1 packet per day, and has recently quit habit for last 3 months. There is no history of smoking or alcohol intake. And there is no history of diabetes, blood pressure, chronic obstructive pulmonary disease or asthma, no history of tuberculosis, cardiac or renal illness. There is no prior history of hospital admission or any surgery in the past. Coming to general examination, patient was conscious, alert and cooperative, average weight, BMI of 22.7, peak of 0. His vitals were within normal limit. There were no pallor, icterus, sinus, clubbing, edema, or generalized lymphadenopathy. Coming to examination, on local examination, on inspection, mouth opening was adequate. Interincisional distance of 5 cm. Our oral hygiene was poor with caries teeth. Mandible was dented, and an approximately 4 into 3 cm proliferative lesion was noted over the right buccal mucosa along the second and third molar, extending over RMT and lower GVS. Well away from the oral commissure and away from tonsillar pillar and TLS. Upper GVS was free, GLS was free. There was no growth or ulcer in the oral cavity elsewhere. No whitish band noted anywhere. Overlying skin was free. On palpation, the similar finding was found on the palpation as well. And laterally skin was pinchable and was free. On Hopkins examination, oropharynx, hypopharynx, and larynx showed no lesion. On examination of the neck, there were no visible swelling, no visible scar, sinus, or fistula. On palpation, there was no cervical lymphadenopathy or any other swelling. On systemic examination, chest was clear with no added sound, equal air entry, cardiovascular and neurological examination were within normal. To summarize my case, my patient was a 58-year-old gentleman, history of tobacco for the last 30 years, presented with an ulcer over the right buccal mucosa with localized pain without any neck swelling or symptoms suggestive of distance metastasis. And on examination, approximately 4 into 3 cm ulcer proliferative growth was noted over right buccal mucosa at second and third molar, involving retromolar trigon and buccal aspect of lower alveolus without cervical. With this, I made a provisional diagnosis of malignant neoplasm of right buccal mucosa. Clinically, T4A M0.
Okay. Any particular reason why you're giving a diagnosis of T4A?
There is a loosening of teeth around the teeth is carious and is loose. That's why I suggest bone invasion by the tumor. That's why I am giving a diagnosis of T4.
Mukesh, you said no history of loosening of teeth in your history.
Yeah. So Mukesh, you have not. I mean, loosening of teeth there is nowhere mentioned, and you have even not extended. You have not explained the lesion. So on what basis have you made a diagnosis of a T4A lesion?
No, sir. On my examination, if I haven't put there was on examination.
I'm just requesting whoever is logging in.
Sorry, sir.
Yourself.
Even if I haven't put here somewhere, on examination, I found loose tooth there, sir, at around the tumor. That's why my diagnosis is T4A. I might have missed to put it here, sir. Sorry for that.
Okay, even if you consider loosening of tooth, do you think that just mere loosening of the tooth would make it a T4A lesion?
No, sir. Loosening of teeth at the site of the lesion suggests, and the lesion is attached to the mandible only, so that strongly suggests mandibular invasion.
So Mukesh, what question Dr. Prashant is trying to ask is there a difference in implication of bone erosion for a buccal mucosa primary versus a primary alveolar primary? Is that, am I right, Dr. Prashant? Is that your question you're asking?
Yes, Dr. Manisha, that's the thing. So does it always mean loosening of our teeth always means a frank erosion? So at least to me, this lesion does not appear that, it is deeply infiltrating. So what are the ways that you can make out clinically that there is a clinical bone erosion?
Frankly, on palpation, there is frank movement of the segment of the bone, or
No. I didn't get you. Movement of the bone in the sense you mean a pathological fracture?
yes, sir.
Oh, that's very uncommon. I mean,
Large paramandibular disease.
Yeah, that's very obvious. Yeah, and that's very uncommon. How frequently do you see a pathological fracture in a buccal malignancy?
That's less common, but that is a definite sign of invasion, sir.
Yeah, less common in the sense, how many have you seen? It's I don't know. I mean, it's very uncommon, and I don't think you can. I agree that any pathological fracture anywhere means that it is a sign of bone erosion. So no, I don't think that's. I completely agree. Okay. Next, anything else?
If there is loosening at the site of the lesion itself, sir, that suggests and bulky lesion around that around close to the mandible, large paramandibular disease.
Mukesh, paramandibular disease will always signify bone erosion.
No, ma'am.
Then why are you telling it as a sign of bone erosion? How do you clinically think that there is bone erosion is the question.
And loss of teeth.
Okay, so yeah, Mukesh. So I would put it this way. One is, the worst come scenario is the pathological fracture, which is very rare to see. And I think that is something which is very uncommon to whatever is my, I mean, I'm yet to see one completely pathological fracture of both inner as well as the outer cortex.
Yeah, I agree with Dr. Prashant. It's extremely rare, and more likely you will see it in post-treatment, possibly in ORN cases, and unlikely to be seen in a upfront oral cavity advanced case.
Yeah. So one of the importance is if you do not have a dentition there, so just mere loosening of the teeth does not always mean it is a full thickness bone erosion. It can be just a mild cortical erosion also can cause loosening of the teeth. So that is one of the thing. Or if there is no dentition, then you could actually palpate the mandible and then make out whether there is an obvious erosion or not. So, or if there is a thickening, there could be some sclerotic areas which could also signify bone involvement. It is not just erosion, but it could be even sclerotic areas which could also imply bone, bone involvement.
And
So-
also, like if I may say, the presence of disease on both buccal and lingual sides of the mandible is kind of more indicative of that you have a through and through bone erosion and your disease is spreading from a buccal cortex towards your lingual cortex. Okay, so that would be one of the signs that you should expect obvious bone erosion.
Okay, so I don't think this can be staged as a T4A from whatever. I mean, you're the best person to have examined there. We are just looking at one clinical picture and then just putting our thoughts into. I see a complete intact dentition except for the last upper molar, which is missing. And the rest of the teeth are there. There might be some slight loosening, but I wouldn't call it a frank T4A purely based on this lesion, because as I don't see the lesion coming on to the gingivolingual side. Retromolar trigone is involved and I do not know. So maybe possibly you're the right person to examine there, but make sure that you take these precautions before you call T4A. Okay. Yeah. Yeah. Anything else?
So, hello, sir. I am Dr. Madan.
Yes. Yeah. Hi, Dr.
Yeah. Mukesh. So, tell us what clinical condition is included in T4A.
Mandibular erosion, skin involvement. These two will make T4A. Besides that, or if the lesion is extending into ITF and Metastasis,
T4A, Mukesh.
for skin and bone involvement will make it T4A.
Only two conditions.
Or thickness of the tumor more than 20 millimeter will also make it T4A.
Correct. So now there is in AJCC 8th edition, thickness is it included?
Yes, sir.
Okay, so now going forward, what do you think, the pathways of spread for this if left like this? How do you think that the tumor would spread, and what would be the difference in the spread of between, a dentate mandible or well as an edentate mandible?
Edentate mandible.
So first, let us take the first question, Mukesh. How do you think that this disease? What will be the progression of this disease?
Disease will progress along the less resistance, so it will grow toward the skin. It can also grow along the pterygomandibular raphe as lesion is extending to the retromolar trigone. Behind through the RMT, it can go along and creep into the floor of mouth and tongue. Posteriorly, it can go toward tonsillar pillar and tonsil, and superiorly, it can involve palate and maxillary sinus as well. Laterally, it will involve a masseter muscle and will go above to involve infratemporal fossa.
Infratemporal fossa. Okay. What is masticator space?
Masticator space is a radiological area below the level of lateral pterygoids.
Okay. Yeah. What is the space below the level of lateral pterygoids and what? Bounded by?
Sorry, sir.
No, complete your answer.
Boundary of masticator space, Mukesh.
Yes. So masticator space boundary would be anteriorly, laterally it will be mandible ramus. Posteriorly it will be maxilla. Superiorly it will be lateral pterygoid.
Okay, what are the contents of mastication?
Yes, sir. Content of muscle will be masseter muscle, and nerve will be B3 nerve, and just medial pterygoid muscle will be there, sir, and
All muscles of mastication. Okay.
yes, sir.
Yeah, mandibular division of the trigeminal nerve. Then what part of the mandible? The ramus of the mandible.
Yes, ma'am. Yes, sir.
Ramus and the
Ramus,
body.
condyle
Yeah.
and
The inferior alveolar nerve and the pterygoid venous plexus.
pterygoid.
Yeah. Does it have any subcompartments?
Subcompartment in terms of high ITF and low ITF, sir.
No, the infratemporal fossa and the space are different. So is there any sub compartments that you are aware of for the masticator space?
So
Okay, so it can be for the benefit, I think you should read about. So it is again can be compartmentalized into submesenteric space, pterygomandibular space, the temporal space, as well as the infratemporal space. Okay. The temporal is again divided into superficial and deep. These are some of the radiological spaces, but the clinical significance of each of this may or may not, but it is, you need to have an idea that it can be further compartmentalized. Yeah. Okay. So now, okay, we'll go with you, and we think that we are dealing with a T4 lesion. Yes, Dr. Vidisha, any comments, Dr. Vidisha, Dr. Madan?
Yeah, I agree with Dr. Prashant. Just Mukesh, just a tip for everybody who's exam going. If you don't have complete clinical and radiological examination, just refrain from staging your tumor so accurately. Okay, here you don't have your radiological information, you don't have your complete distinct. So when you are giving your TNM status just at the end of your clinical examination, it won't be accurate, obviously, because you don't have information. So for the exam going students, read your imaging also completely, and then finally stage your tumor would be my thing I will like to say. And coming to this case, Mukesh, what did you do next for the patient? What imaging was of your choice? What did you choose and why?
I did CT scan of contrast CT scan of head, neck, and thorax. This will give me idea about the epicenter of the disease, size of the lesion, extent of the lesion, involvement of the bone, along with nodal status and metastasis.
So any particular reason why you didn't choose MRI, in the sense, if let's say assume that you have only an MRI, so what would be your better imaging outcome, whether it will be a CT or an MRI in this scenario?
Ma'am, in for primary, CT is always the primary choice because it will show the better bony involvement, and MRI is used only as a troubleshooter in cases of nerve involvement or ITF involvement or marrow involvement. In those cases
So
only MRI.
which is your investigation of choice? First for bone involvement, secondly for soft tissue involvement. And for about when you are asking about bone involvement, tell me when you are having Gross bone erosion versus when you are not expecting gross bone erosion, which is the better investigation of the two?
Ma'am, early superficial erosion is better in MRI, while gross erosion will be better in CT.
Okay, and what happens if you have only MRI? How does MRI fare for superficial bone erosion?
If we have only MRI, ma'am,
What is the, are you aware of any literature regarding sensitivity and specificity of the both modalities CT and MR regarding bone involvement?
no, ma'am, for bone involvement as such is not for, no, ma'am, for bone involvement.
Okay, any other specific areas? I gave it to you that you will do a CCT head and neck as a basic investigation in majority of your oral cavity cases. Okay, I give that to you. But can you tell me specific areas where would you like to add an MRI to it? We are talking about buccal mucosas. Let me not confuse it with the tongue patients. It's obvious that you will do an MRI.
Okay, ma'am. In cases where ITF involvement is expected, marrow invasion is expected, or DNI is suspected, I would add MRI as well.
Okay, so specifically in this RMT lesion, which we are saying clinically is involving RMT, would it make any sense if I said that I want to do just an MRI? Would it be bad, good, or would it be worse? What will be your judgment? This thing, what would you like?
Ma'am, with this imaging only, I am imaging neck as well. So for nodal involvement, ma'am, CT is better. Sensitivity of CT and MRI is both.
Says who? Which article are we quoting here? And assuming that this is a clinically N0 neck.
They won't.
What?
They won't meta-analysis.
This is about what, Mukesh? Is it about CT and MRI in a sensitivity about?
Yes, ma'am. All CT, MRI, UC and UC.
MRI will also image neck, right? It's not that you are going to image only primary.
Ma'am, but specificity of MRI is quite low compared to CT.
Just for the exam going people, there are very good articles. One of them is by a TMH group, which is a Devendra sir's article. It compares sensitivities of different modalities, USG, CT, MR, about diagnosing a neck node. Please go ahead and read it. It will be very useful for the residents specifically. Anything more you would like to add, Dr. Prashant, Madan, about imaging in this particular case?
No, good, all good. So one question to Asim. I think we've already covered that, Vidisha. When would you ever get an MRI? I don't know if it was covered, if I missed it.
No, yeah. This is a cyclical series. So last year's exam going have passed out now. So we have the new freshers joining in. So the discussion can definitely go ahead for that.
Okay, fine, yeah, sure. So yeah, so when would you, is there an indication for an MRI at all in a buccal mucosa cancer? Is there any specific situation that, in addition to CECT? No, undoubtedly, as pointed out, CECT is the investigation of choice. It gives you an MRI is not required in all cases because of, though it may give you similar, it gives you similar information or maybe slightly better, but does not add on much. But there are any condition that you would get.
Yes, sir. If I suspect ITF, high ITF involvement, for PNI, for marrow involvement, I would like to add MRI.
Yeah, good. So I think that is, these are some of the indications for getting an MRI wherein you have a high infratemporal fossa involvement, but you have not, and you're still planning for surgery in these group of patients. Then you would want to be sure that you're not dealing with something where, you're going to leave an R2 disease and then come out. You have to ensure that you have to get, and what are you specifically looking for in MRI in high ITF involvement?
Involvement of foramen, ovum, well. That will on CT, I will have only indirect evidence of foramen widening, while in MRI, I can say the enhancements along the nerve that is standing better.
Okay.
These two things specifically for the environmental foramen oval. So that will make the disease unresectable.
Okay. So these, yeah. Okay. Yeah. Go ahead. Go ahead. So you have a radiological. It's a T3 lesion. You have the images.
Yes, sir.
You yeah, run across the images and then.
I did the CT, and this is the CT contrast enhanced CT scan. So the CT showed that there is no structure.
Okay, okay, it's okay. Let's move on, not to waste much time. Let's presume that there are no
It will
lung
be quick, sir.
metastasis and there is no bone erosion on CT. Okay, is that okay?
No, sir. There is erosion.
Oh, there is erosion. Let's presume that there is no bone erosion. Is that okay?
Okay, sir.
Yeah. So for the sake of discussion, let us presume that there is no bone erosion
Okay, sir.
and no lung metastasis. Yeah. Okay.
Okay, sir.
And you've done a biopsy, which is a moderately differentiated squamous cell carcinoma.
Yes, sir.
Yeah. Were you considering any other differential diagnosis other than squamous cell carcinoma in this patient? No, because when you gave your differential diagnosis, you said malignant neoplasm of the buccal mucosa.
Yes,
so what else was there in your mind?
Here my first diagnosis would be because squamous cell carcinoma is most common oral carcinoma, sir. And I think it's malignant only because it's long standing, fast growing, and not relieved by other medication, and there is no other traumatic trauma causing agent there. So my diagnosis was malignant, and squamous is the commonest. That's why I made.
So then why did you, then what else did you have in your mind is the question?
And
Because
there can be soft tissue sarcomas, bones, and other bony sarcoma like things, sir, other than epithelial carcinoma. Or here,
other than epithelial, what are the other things? Please spell out the differential diagnosis.
rhabdomyosarcoma, osteosarcoma.
Rhabdomyosarcoma in an adult?
No, sir. It's common in children, but still very less common. There can be sarcoma, soft tissue sarcoma.
Soft tissue sarcoma will have a lesion like this, which is an ulceroproliferative.
No, sir. That would be a smooth, bulky growth, and but
So
primary diagnosis would be this.
yeah, so
carcinoma only.
what I'm trying to stress upon here for the exam going students, if you feel that it is a, you don't have a differential diagnosis in this particular case, I am not sure whether we could give a differential diagnosis. May I request the others to mute their. Thank you. Yeah, so when you see a lesion like this, it is absolutely fine if you don't give a differential diagnosis and say it is carcinoma of the right buccal mucosa, rather than being very vague in telling malignant neoplasm of the buccal mucosa. Okay, keep that in mind. As exam, I mean, in the exam, if you have a diagnosis and you cannot fit this into, I am sure you cannot fit this into any other differential diagnosis.
Yes,
So then it is good, it is better, and it is advisable to pinpoint and say that it is carcinoma of the right buccal mucosa, so on so stage, rather than just being very vague in your diagnosis. Okay?
Okay, sir.
Yeah, go ahead.
I made a diagnosis of moderately differentiated squamous cell carcinoma of right buccal mucosa after biopsy. As on the scan, mesenteric space was involved, mesenter was involved. Staging of clinical T4B and 0 was made. There were no notes.
So what is the group staging?
The stage 4B.
Yeah, of the four, what four? 4A, 4B, 4.
4B. Yes, sir. Stage 4B.
Okay. Yeah, go ahead. Yeah, what do you want to do now? You have a diagnosis, you have the radiology with you. You have staged it as a T4B, N0, M0.
I would like to treat the patient with curative intent, so I will opt for surgical treatment for this patient. And as the disease is localized at retromolar trigon involving masticator space and bone incision, I will do the segmental mandibular to posterior segmental mandibulectomy. And as the disease is also approaching the upper alveolus, I will like to do upper mucoperial stripping as well, neck dissection and reconstruction by pectoralis major flap, as followed by adjuvant treatment.
So why not? Why are you choosing for a surgical option in this patient, and why not a radical radiotherapy in this patient as a curative choice?
Sir, radiotherapy in advanced buccal mucosa cancer has much more inferior outcomes, sir. There was one attempted trial by Robertson et al., which held because of the much poorer inferior outcome in the radiation group, sir. And study was aborted prematurely because of that. So surgery is the treatment of the choice for advanced
So
buccal
is it
mucosa.
surgery alone, or is there something else as the treatment of choice?
Surgery followed by adjuvant.
Yeah, so it's a multi-modality treatment. You have to always keep in mind that patients that are advanced disease have to be offered multi-modality treatment, and those patients that are early have to be offered single modality depending on the choice after explaining to the patient. So it's a multi-modality treatment. Okay, and you would explain to the patient about which is better over the other and what is the advantages of both. Okay, so yeah, buccal mucosa composite resection, which would require a posterior segmental upper mucosal. Okay, what neck dissection? What would be the extent of neck dissection you would do in this patient?
Since clinically the patient is young, I would like to do selective neck dissection of level 1 to 4. That will.
So why do you want? Why do you want
of
fourth level?
Sir, 1 to 3 level will clear about 91% of node will include, but including 4, we will have gain of another 5% and will be 96% sure of.
So which data is this? Where are you talking about this data from for a buccal mucosa? 96% and 91% for level
from Tata Group itself, sir, by Malviya et al.
Pardon?
Malviya et al. Study done at Tata itself.
So I'm Dr. Vidisha, you want to talk about it, because I'm sure that Dr. Pantvaidya's paper did not say that you should routinely do level 4.
Yes, I agree with you, Dr. Prashant. That is what the paper said, Mukesh. What did that
Yes.
paper tell us?
paper the paper has said that decision for doing 2B and 5 will be guided by 2A. But that has mentioned the 1 to 4 inclusion will
Was that the conclusion of the paper? Was
No,
that
sir.
the conclusion of the paper?
Conclusion of paper is level 5 and level 2B dissection. 2B dissection should be directed by the positivity of level 2A. And for tongue and RMP, if 2A is positive, then go for 2B. And for buccal mucosa and lower alveolus, if 2A is positive,
And
go for
apart
5.
from tongue and RMT, if 2A is positive, you don't need to do 2B.
Sorry.
Mukesh, I'm
Yes,
sorry to interrupt. Mukesh,
Yes, sir.
see, what happened was that in that 583 neck dissection article, the prospectively they are analyzing the incidence of metastasis. So whenever somebody is asking, what is the intent of that paper? So you have to tell the primary intent of that paper to find out the incidence of metastasis at various levels. Do not
Yes,
start telling your conclusions, which we are deriving and practicing from that article. So whenever quoting an article, ensure that you are telling what the article intends to study.
Yes, sir.
So the paper only tells you the incidence of lymph node involvement of at different levels, and what if one level is involved, what is the incidence of level of involvement of the other. Possibly you could avoid, but then you do not, as of today, you do not have evidence to say that whether you can completely avoid doing a comprehensive neck dissection or not. So that's the, I mean, you know, there is no data to suggest that if you avoid, your recurrences will be less. And so please always, when you read a paper or when you quote a paper, please understand the aims and objectives of that particular paper. So lesser incidence doesn't mean is always translated to lesser incidence, lesser dissection or more dissection doesn't mean that is always translated to better outcomes or worse outcomes. Okay, Mukesh.
Yes, sir.
Yeah, so you have to always stick on to the standard treatment protocols. And yes, you would want to do, if you say, I'm okay with if you're saying that you would do a, in an N0 neck, you would do a level 1 to 3, that is a selective neck dissection 1 to 3, and then send it for frozen if you have the facility. If the frozen comes negative, I would stop with that, is absolutely fine. Okay.
So
Yeah,
Mukesh,
I mean,
what are the indication for NACT in oral cancer?
NACT, for NACT, if we expect a negative margin, advanced, totally advanced disease, in which negative margin is doubtful in that, or for preservation of mandible preservation, if not, there is no erosion, paramandibular disease with no bone erosion.
Unmute.
Mukesh,
Yes, sir.
Dr. Vijay Patil paper.
Sorry, sir, I haven't.
5 indication.
Sorry, sir.
You know, Madan, I agree that our NACT paper is there, but for exam going people, I would like to say that NACT is still not the standard of care,
Yeah, I
and
agree,
it
ma'am.
is not
Yes, agree.
accepted worldwide as a standard of care treatment. And the indications for giving neoadjuvant chemotherapy in an oral cancer are still under investigation. Okay, so we don't
agree,
have a
ma'am.
randomized evidence right now. So for the people who are exam going, I would like to say that please do not commit yourselves based on 1 or 2 papers. Kindly define. You have to tell that these are phase 2, that NACT mandibular preservation, whatever is there, it's a phase 2 study. The current studies which have been published regarding NACT have not shown benefit of NACT in oral cavity cancers. Whether you say Lycitra, it was no benefit of overall survival. The main aim of that study was overall survival, which it did not meet that endpoint. Okay. And the conclusion of organ preservation was not the primary endpoint. So it's not a standard of care as of now. It is still under evaluation. Exam going people, please understand this.
Yes, ma'am. For upfront resectable, agreed. But for where there is doubtful resection, like if lesion is just reaching up to the high ITF or borderline reaching zygoma, and if tongue lesion is just if facing the vallicula. So
Yeah,
in
so
this case-
yeah, Dr. Madan, just to keep it simple, I completely agree with Dr. Vidisha that the role of neoadjuvant chemotherapy in oral cavity is purely investigational as of now. So that I think we can be discussed on a case by case basis, because if you have a lesion which is going on to the vallicula, if you have a lesion going on to the oropharynx, high infratemporal fossa. So in short, actually, Dr. Madan is trying to point out the different indications where you may consider. Okay, I wouldn't say you will consider. So the
Yes,
one of them is a high infratemporal fossa involvement, or you have a disease reaching down below the hyoid, or you have edema reaching beyond zygoma, or edema reaching the into the neck. Okay, so these are some of the edema reaching till the hyoid. These are some of the possible you may consider, and that too not outside, preferably not outside. Yes, but this is on a case to case basis.
yes, yes.
Yeah. So to be in short, for all exam going, it is not the standard of care. None of the trials have shown superiority over patients who have undergone definitive, and there is no randomized control trial to say that NACT followed by surgery is better or superior or inferior for that matter to concurrent chemoradiotherapy in majority of this. Okay, so yeah, so now let's consider that. Yeah, Mukesh. So
Sir, in Licitra trial itself, there was better mandibular preservation and lesser need of adjuvant RT after NACT.
So Licitra, actually, Vidisha has already pointed out on the Licitra trial outcome. So it was not intended to do for organ preservation. So I don't think you can make a comment. And whatever trials right now for organ preservation going on, it published at TMH is a phase 2 randomized phase 2 trial, and a phase 3 trial has taken. So we will be hoping to wait for that. The results to see whether organ preservation is feasible in this or not in oral cavity cancers. Okay, the survival is apart from. Okay, so now you have gone ahead with surgery. What is the minimum margins that you would be looking at when you operate these patients?
I would try to take a margin of 1 centimeter so that pathologically after shrinkage, it would be more than 5 millimeter. So my target will be more than 5 millimeter pathological margin.
So you have said that your CT scan shows a masticator space involvement, correct? So what will be your third dimension margin here when you're operating, and what precautions that would you take?
I would like to do the compartmental section with clearance of the masticator space along with the mandible and the masseters as a whole.
Mukesh, this is just theory, Mukesh. So I want you to tell practically when you're operating, when you're on table,
Yes,
tell
sir.
us some tips to ensure. See, the third space is something that which you cannot see.
Yes, sir.
Okay, so but how do you, and you which you will never get on frozen also.
Yes, sir.
Frozen is not going to give you third space margins.
Yes, sir.
Yeah, so how do you ensure? Tell me practically, how do you ensure that you have got away with a good third space margin?
Sir, on resected specimen, I will examine the resected specimen to.
No. Even before you resect, there is no re-revision. Even before you resect on table, when you are about to resect, what precautions would you take that you have? What you will ensure that you get a complete good third dimension margin? Okay. So I'll make it simple for you for the interest of all the residents who are here. So the third dimension margin is something that which is very crucial, and it is important to read your scans well before you go inside. Okay, so mucosal margins are very uncommon that you would fail on a mucosal margin unless and until you have some post treatment wherein you're not able to see the disease. Very rarely that you would go wrong, but on the third dimension margin is purely radiological margin. So that is, you have to read your films and then go. So what small little precautions that you need to take, that it's going into the mesenteric space. So take the entire mesenter, your mucosal cut and your soft tissue cut. In fact, I would say the soft tissue cut is 1 centimeter higher than your mucosal cut to make sure that you get good adequate third dimension margin. So the mesenter is completely taken down, and you should take it en bloc. If you're taking an upper alveolus here, definitely when you do an upper alveolar mucoperiosteal stripping. So I would be very unhappy if this patient has a masticator space involvement would just to do an upper alveolar stripping, because I would fail on the third dimension. Okay, Mukesh, because
sir, yes, sir. My sitter only lower fibers were involved on imaging.
so that's what I'm trying to tell you. If you have a masticator space involvement, it may be very challenging to get an mucoperiosteal stripping and then just still get away with the margin. So these are some of the precautions that you need to take. And also the pterygoids, try to encompass the pterygoids as much as possible. Because these are all your components of your masticator space. Okay, so your entire muscles of mastication along with your pterygoids, all these things have to be taken. So this is something which is a very difficult margin to comment on frozen section, and it is very difficult to revise. So there is no revision of these margins possible, practically possible. So you have to do it at the same time. Okay, so keep these in mind when these are some of the practical points that you need to take into consideration while operating, especially patients with T4B disease.
I agree with you, Dr. Prashant. Point very well made. Another thing I would like to add in here is similarly in the RMT, like in this patient, your third dimension would be your medial pterygoid. Okay, what Dr. Prashant was talking about soft tissue margin. Am I right, Dr. Prashant?
Yes, exactly. So
Yeah,
the medial pterygoids are.
Yeah, when you are having a disease in RMT, the medial pterygoid will be your base. So be very careful, as Dr. Prashant has said, to take an entire medial pterygoid as your base in that region so that you don't fail on the soft tissue areas.
Yeah, okay, Mukesh. So what are the things that you would look for in histopathology?
Histopathology, the primary look for margin, adequate margin.
Look for margins. All margins are more than 5 millimeters and free of tumor. Okay.
Skin and bone involvement.
You have not removed the skin, I suppose, because you didn't tell us.
Bone involvement. Whether bone is involved or not histopathologically.
Yeah, bone is involved.
Then nodal evaluation, sir. How many nodes are involved?
More about the primary. Anything more about the primary before you jump on to nodes?
Size of the tumor.
Okay.
Differentiation of the tumor.
Okay.
ENI, lymphovascular, perineural invasion, lymphovascular invasion.
Okay.
Pattern of invasion.
Okay, pattern. What do you mean by pattern of invasion? Pardon, I can't hear you. Hello. Yeah, Mukesh, are you there?
Yes, sir.
Yeah, so tell me, go ahead. What do you mean by pattern of invasion? What is worst pattern of invasion? WPOI.
Yes, sir. Is equal to Brand-Wilson and Wessler classification, sir. They have classified as type 1, 2, 3, 4, 5. So type 5 would be the poorest one.
Okay, so for all exam going, it is important that you know what do you mean by worst pattern of invasion. Okay, so it depends upon what exactly the tumors are like. For example, you have one which is a broad pushing pattern, 2 is a finger-like, and 5 is something with satellite nodules. Okay, that are 1 mm away from the main tumor is about 5. Okay, so this you should have an idea about the worst pattern of invasion. Then what else? You would look for size, the depth of the tumor.
Yes, sir.
Okay. It's important that you would look for depth of the tumor. What is the difference between depth of the tumor and tumor thickness?
Depth of the tumor is from the normal mucosal surface to the maximum depth of the tumor, while tumor thickness is the highest part of the tumor to the depth of invasion.
So it takes into component the proliferative part of it also. Okay, the thickness.
Yes, sir.
Okay, so the depth of infiltration is only from the mucosal surface below which whatever is the depth goes. Okay, then the differentiation grade, anything else? Do you want to know about lymphovascular invasion?
Yes, sir. Yes, sir. Lymphovascular invasion and perineural invasion.
Yeah, perineural invasion. Yeah, okay. So these are the other things when it comes to primary. And then for lymph nodes, what do you look for?
Number of nodes in node, whether extracapsular involvement is there or not.
Okay, if there is an extracapsular involvement, how does it change your nodal staging?
It would be 3B and 3B disease, and along with adjuvant radiation, adjuvant chemo.
We'll come to that. Yeah, we'll come to that, Mukesh. Yeah, okay. So these are some of the things that you would want to consider in your pathology. Okay, in your histopathology report, this is what you would be interested to look into. Okay, yeah. So now you have a PT4B N1, all margins are free. LVI positive, PNI positive. Poorly differentiated squamous cell carcinoma with a worst pattern of invasion 3. So how would you like to proceed?
For N1, PNI, and LBI present, sir. I would like to give the adjuvant radiation to this patient to make an primary.
Okay, so based on why not concurrent chemoradiotherapy, considering that the patient has multiple other features like LVI, PNI, poorly differentiation, worst pattern of invasion of 3.
In the absence of positive margin or extracapsular nodal involvement, I would not like to add the chemo for this patient because that will add extra toxicity, and there is no extra proven benefit of adding chemo without the extracapsular involvement or positive margin.
Okay, based on what evidence are you making the statement?
Earlier and Cooper study, sir,
Mm-hmm.
and which they have found the addition of chemo is beneficial in cases of involved margin and extracapsular spread in wound.
Okay. Yeah. Yeah. Dr. Vidisha, anything to add on? Dr. Madan?
Mukesh, are you aware of any studies that are talking about chemoradiation except all these two indicators which we already know? Are you aware of any evidence that says to give chemoradiation when you don't have the positive margin and ENE? Are you aware of any other this thing? what we usually call as soft indicators. That is what Dr. Prashant is trying
Yes,
to
ma'am.
ask you. Are you aware of any evidence for that? Are there any studies which are saying that there is benefit, or are there any other risk factors which we should take into account other
Yes,
than
ma'am.
the ones?
Yes, ma'am. Other than multiple minor factors like PNI, LVI, or poor differentiation of the histology of the cell, and higher worse pattern of invasion. These are soft indicators. If multiple soft indicators are there, without even if there is no positive margin or extracapsular spread, we can consider chemotherapy for better outcome.
Do you have any literature for that, or we are just saying as per practice? Do you know any studies that are saying? Okay, for just to summarize this, see, we don't have any randomized evidence so far to say that giving chemoradiation for soft tissue soft indicators such as all these other factors apart from positive margin and a ENE are beneficial for CTRT, but there are emerging articles coming. This is still under investigation and individualized institutional practice. So when you are answering in an exam, what you have told is the one which you should said about Bernier Cooper's is the evidence that you use for giving chemoradiation, and be aware of other soft indicators such as lymph nodal burden, lymph node ratio, and other poorly differentiation, WPI, all such soft tissue factors you should be aware about.
So what would be the dose of radiotherapy in the adjuvant setting?
In adjuvant dose is 57. Yes, sir. And
You're not audible, Dr. Mukesh. You're not clear.
yes, sir. The dose is 57.6 grade for adjuvant.
57.
Yes, sir.
Okay. So, Dr. Madan, you have any?
Yes, sir. I think it ranges from 54 to 60 gray. It's not exactly, it's 57.
Okay. Yeah, and if you want to give concurrent chemoradiotherapy in this patient, so would you choose a weekly? What are the drugs that you would want to use, Mukesh?
Cisplatin and fluorouracil.
Okay. Cisplatin and
Fluorouracil.
both, or only cisplatin?
Only cisplatin, sir.
Okay, at what doses and what
100
schedules?
100 mg per meter square. Weekly.
100 milligram per meter square, weekly, 3 weekly,
Weekly, sir.
but 100 milligrams weekly.
Yes, sir.
So are you aware of two major trials that have come up looking at the scheduling of the chemotherapeutic agent in concurrent chemoradiotherapy? Both the trials are conflicting results. Are you aware, Dr. Mukesh?
For now, I don't remember, sir, but
So one of the trials is from Tata Memorial Hospital. Okay, so both the other trial is recently published. I'm sorry, I'm not getting the name of it. So both the trials have. Vidisha, would you like to help me with the trial?
Sorry, I was logged out for a minute. I missed the discussion. What were we saying? Sorry.
Yeah, we are talking about 3 weekly versus weekly cisplatin. One of the trials is from TM.
Vanita Narona, Dr. Vanita Narona,
Yeah,
she has
Dr.
published
Vanita's
about
trial.
weekly versus
Yeah.
3 weekly. It was about 30 milligram per meter square weekly versus 100 milligram per meter square 3 weekly cisplatin. But however, that study has shown that weekly cisplatin was inferior to giving 3 weekly, and hence still 3 weekly cisplatin remains standard of care.
Yeah. Sure. So I think you should read up these trials. You should have an idea because these are things that which is mandatory, and you need to know the doses, whether you're giving 30 or 100 milligrams. You need to be aware of the doses. Yeah. Okay. What is the morbidity that you would expect in this patient? Long-term morbidity.
Chewing, there will be problem with the chewing and shoulder weakness. And local radiation toxicity in form of leukocytes, dry mouth.
Okay. So how would you rehabilitate these patients?
So early speech and swallow evaluation and swallowing exercises.
Okay. So when would you start these rehabilitation?
From the immediate post-op period only will start with it. If there is we'll start with guide bite prosthesis. We'll evaluate for speech and swallow evaluation. If mouth opening is restricted, we'll start with jaw stretching exercises, chest, neck and shoulder physiotherapy.
Okay. So Mukesh, I beg to disagree. So the rehabilitation starts even before you plan the patient for surgery. Okay. All patients, remember that all patients have to be counseled and taught about exercises even before the force. You'll have to explain to them that what the complications that they foresee, and it has to start in the preoperative setting. Okay, so please make sure whatever you said is true in terms of speech, swallowing, okay, glide bite processes, measures to avoid trismus, measures to reduce shoulder morbidity, and measures to also not only shoulder morbidity, but also the hand, neck, and shoulder. So all of these are very, very crucial. And most of the times the rehabilitation should begin in the preoperative period rather than in the purely in the post-operative period. It becomes much easier. Okay, so keep that in mind and then you can take it. Yeah. So if you're not ready to rehabilitate a patient, I don't think we should be resecting. Okay, any further questions? And I mean, that's.
Video start. I believe we will stop the discussion here now, sir. Thank you, Mukesh. I would request you know all the answers, but you need to prepare them well so that you are able to answer them during your Viva. It's more important that you are able to coordinate all the answers, all the things that you know, and you are able to give a comprehensive reply to the examiner rather than just knowing the right answer. And I thank all the examiners, Dr. Prashant Pennamadu, Dr. Vidisha Tuljapurkar, and Dr. Madan. And I'd also like to thank Dr. Natarajan for his expert talk. For the next session, we'll be meeting on 8th of September, and the topic will be differentiated thyroid cancer. And this is going to be a very good discussion. So I would welcome you all once again for the same. Thank you very much.
Thank you, Asim. Thank you, Prashant, Madan. Thanks, Mukesh.
Thank you very much. Yeah, Mukesh, well presented. All the best. Thank you.
Thank you, sir.
Thank you.